welcome to the Symposium sponsored by bioMérieux on the use of biomarkers in the management of acute kidney injury inside the program of the International Vicenza course on AKI and CRRT. We have the pleasure to guest two important speakers today, which is Professor Louis Forney from UK, a big expert in biomarkers, and Professor Dan Helgeman from the Heart and Vascular Critical Care Services at Bay State Medical Center and University of Massachusetts Medical School Bay State Medical Center in Springfield, Massachusetts. Without further ado, I would like to start immediately asking Professor Forney to share his slides and to begin the presentation concerning AKI in the critically ill patient. I think that it will be extremely important to hear what is the perspective of Louis and the possibility to use biomarkers in this condition. Louis, please.
Thanks very much, Claudio. It's a great honor to be at the Vicenza meeting again. It's just somewhat sad that we're not in Vicenza, but we're there in spirit. So I was tasked today with talking about the use of biomarkers in the management of the critically ill patient, but also, in the critically ill, but also my view on that, really. So just a few housekeeping things. I'd like to thank also Clinical bioMérieux of sponsoring this symposium. So we'll have a bit of a basic run through about biomarkers and set the scene really for Dan, who's going to talk about some clinical uses of the biomarkers. But this is my view on where we are and where we're going, really. So firstly, what is a biomarker? It's a term that's bandied around a lot. It's a naturally occurring molecule, gene, or characteristic by which a particular pathological or physiological process can be identified. So it can be any test that we use to understand what's going on in our patients when we're talking about medicine. So serum creatinine is a biomarker, urine output is a biomarker. But we tend to think of biomarkers as being the new novel types of molecules. Now, I could talk about these, right? I could just bamboozle you with lots of rock curves and pictures like this. And really, there's little point. The statisticians among us can look at those to their heart's content, but I thought I'd give you more my views. Now, a part of the problem with discussing biomarkers is that you get colleagues of yours that are less enlightened, shall we say, tend to have the same complaints when you talk to them about biomarkers in acute kidney injury. You can't do anything about AKI. We do everything on ITU anyway. I know when my patients get AKI or are going to get it, one of my ex-colleagues used to say, and biomarkers are expensive and add nothing, right? Well, here's a great quote. If I would have listened to the naysayers, I would still be in the Austrian Alps yodeling. So normally I would ask the audience who they thought that quote is attributed to, but in fact, I'll have to pretend that you're guessing, and it's actually Arnold Schwarzenegger. So the once governor of California had quite a lot of insight there. So do we need acute kidney injury biomarkers? Well, this is a simple slide to show the difference between us and cardiologists. And I think the main conclusion we'll come to is the fact that nephrologists are slightly more reserved. So here we have acute myocardial infarct. Look at all the developments in terms of assays and analytes for diagnosing acute myocardial infarction, and look at acute kidney injury, right? We're the same now as we were in the last millennium. And this is part of the problem, right? Part of the problem is AKI has a myriad of causes from this excellent review article in the Lancet, but we just use a single analyte to identify all these causes. And so the problem in some ways is creatinine. Now, under stable, steady state conditions, creatinine is fantastic. It's excellent for assessing CKD, but it's pretty useless, I think, for predicting AKI. So even though currently we define AKI as changes in serum creatinine, it has significant limitations. It's limited by muscle mass. That's particularly a problem in our ITU patients, as in nutrition. The ECF volume, which can shift considerably in our patient stay, as well as relatively high false negative, positive rates. So how can biomarkers help us? Well, they can measure the response at the cellular level. And also the response depends on the injury type and the type of biomarker. So a marker of tubular injury, for example, might be completely useless in a case of volume depletion, whereas serum creatinine would be elevated, and that's all it would tell us. But you can also get this concept of positive biomarkers with no change in serum creatinine, so-called subclinical AKI, which some people dismiss. And I would tell you that, in many ways with biomarkers, there's no such thing as a false positive or false negative. And so-called subclinical AKI, you ignore your peril. This is a good general overview of the effects of subclinical AKI. It's pooled data from several studies looking at emergency department patients, and the biomarker in question was NGAL. And these are ED patients, non-selected, okay? So this is dialysis, mortality, and a combination of the two at 30 days in this population. And you can see the overall mortality rates around 4 to 5%, which is about what you see in any general medicine intake into an acute hospital. Now, if you look at patients that are serum creatinine negative for AKI, but NGAL positive, you can see there's a significant elevation in terms of mortality and dialysis. Higher, indeed, than those with serum creatinine and NGAL negative. Obviously, the combination of the two is significant. So biomarker positivity is associated with quite significant risk. So positive biomarker is bad news. The other thing is that we really don't know about the anatomical lesion when we just look at serum creatinine or urine output. We can't tell what's going on in terms of phenotypes. So do all nephrons respond similarly to injury? Are specific cells targeted? And is a response stimulus specific? Biopsies may tell us that, but of course, the role of the renal biopsy in the critically ill patient is fairly minimal, mainly because of the risks associated with it. And quite often, you see little in terms of gross anatomy. I mean, here's a very simple example of that. This is a rat kidney. This is a control rat kidney being stained for NGAL. You can see under control conditions, there's no expression of NGAL. If you expose the animal to volume depletion, again, there's very little expression of NGAL, but ischemic injury, you see quite a significant pattern. So here you get a different response depending on the injury. And so, for example, if you look at NGAL, then thick ascending limb is one of the areas where it gets expressed. Whereas if you look at another biomarker, KIM1, kidney injury molecule 1, you see a different, completely different pattern. So the biomarkers can tell you something more specific than just a simple change in creatinine. Now, there are hundreds now. This is a simple diagram just outlining a few. And we've got over 3,000 papers so far on AKI and biomarkers in the literature. And yet, I have to say, naysayers are still winning in that biomarkers haven't been adopted as globally as we'd like. So can they actually help in clinical practice? Or when might they be needed? Well, they may be needed for assessment of risk, for recognition of early AKI, differential diagnosis, and perhaps targeted intervention. Which ones should be measured? Well, functional markers, markers of damage, or a combination of the two. This is something that the ADKI group have explored in some detail. How should results be interpreted? Well, this is interesting, of course, where a single biomarker shot, if you like, or multiple testing expressed in terms of PPV and negative predictive value. And how should data be used for management? And this is key to intervening with our patients. So guiding timing and nature of interventions and improved process of care. Now, a simpler way of looking at that is something I call the 4 Ps: prediction, prognostication, phenotyping, and pharmaceuticals. Now, this one's really weak, but I couldn't think of another P. So if the audience can help me, please email me back. So if we look at prediction, right, there are several electronic predictors out there now, models, digitally enabled or otherwise. This is one that got published in Nature Medicine, backed by Google, digitally enabled care pathway for acute kidney injury. It uses routine collected electronic hospital data collection. This is the ISACI study, one that I was involved in, an impact analysis of a clinical prediction rule. So these are electronic alerts we can use to predict the risk of acute kidney injury. If we add a biomarker onto that, can that help? Well, in fact, this is something that we did do. We showed that improving clinical prediction rules in acute kidney injury can be enhanced significantly if used biomarkers of cell cycle arrest in this case. This was a pilot study, something we're expanding on now. And what the results show in brief is that if you have a patient that the clinical prediction rule deems as low risk and your biomarker is low and your negative predictor value is over 97%. So that's really quite significant in terms of resource allocation. Remember, these are unselected, acutely sick medical patients, but pre-ITU. So we're managing to rule out a significant number that would have further investigations for acute kidney injury. So what about prognostication? Well, that can be applied in several ways. You may recognize this graph here. I'm not going to delve into a lecture on timing of renal replacement therapy, but this is a study, the Elaine study, which you're all familiar with, I'm sure. Why am I mentioning that? Well, in fact, the patients in this study were enriched by having a positive biomarker. So patients with acute kidney injury were then selected out above and beyond by the presence of a positive biomarker. And so this is particularly useful in biomarkers in the future, maybe able to enrich population studies for looking at intervention. How else may they help in prognostication? Well, some of you may be aware of this study. The Ruby study, which is published this year in intensive care medicine, a multi-center study, 21 sites, 12 in the US, 9 in Europe, looking at the outcome of patients with stage 2 or stage 3 as defined by KDIGO. And a cohort of potential biomarkers were looked at to try and determine which ones were best at predicting the need for renal replacement therapy. So persistent acute kidney injury. Lots were looked at, and in fact, the best significant or the most significant one was urine, the CCL14. So this is important in monocyte and macrophage recruitment, and high levels may be involved in inflammatory cell trafficking, leads to increased tissue damage and fibrosis. So this was the first report on this new biomarker. And if you're interested in rat models, it won't be particularly good because it's not expressed in rodents. So these are new biomarkers that can point to a persistent AKI. And so you can imagine where they could be adopted for new technologies in terms of treatment of AKI, but also, dare I say it, for doing studies on timing of renal replacement therapy if we need any more of those. And so pharmaceuticals is really, interventions. And so this is the Prevaki study, which I'm sure you're aware of. This was high-risk patients defined as having high nephrocheck or TIMP2 IGF BP7 undergoing following cardiac surgery. And I'm sure you know the results of this, that the intervention group had a reduction in acute kidney injury. And the intervention group mainly had an increased use of dobutamine, correction of hyperglycemia, and more attention spent to ACE inhibition. And they found a reduction in all acute kidney injury and in moderate and severe also. Another biomarker guided intervention study you're aware of is the Big PAC study from Germany, looking at prevention of acute kidney injury after major surgery. Fairly heterogeneous group, some cancer surgery, some transplant, some vascular, but overall the control group did less well in terms of incidence of acute kidney injury than the intervention group. This didn't use a KDIGO bundle, this used a slightly different approach. So the last area I'm going to discuss briefly is phenotyping, and this is particularly useful when you consider that not all AKI is equal. It's syndromic, it's not diagnostic. And this is something that the ADKI group have commented on fairly recently. This came out just last month. It's the latest recommendation from the ADKI group on acute kidney injury biomarkers. And this is a picture that you've probably seen before in various guises, where we can define a patient as having no functional change or indeed damage. So no risk of acute kidney injury. Patients of loss of function without damage, damage without loss of function, so that would be subclinical AKI, for example, and damage with loss of function would be more intrinsic renal function. And so new definitions of acute kidney have been proposed based on this. So the subclinical will now be viewed as a stage 1S, which is no change in serum creatinine levels and no urine output criteria, defining acute kidney injury, but biomarker positivity. And then stages 1, 2, and 3 can also be defined in terms of biomarker change also. And one of the things about assessing your biomarkers is that you can then integrate that into a system where you go back and reassess your patient. And so you may see progression through the early stages of acute kidney injury, but may also see resolution. So the future, well, this is what I hope the future looks like, and I'm sure Dan will show us a glimpse of the future. So you may be able to use prediction tools. Then if AKI is suspected that the patient's at high risk of acute kidney injury, biomarkers of structure and function may be utilized, and then diagnose your acute kidney injury on the basis of a sniffer plus a biomarker. And then if you have AKI, then a particular biomarker or panel of biomarkers may be used to define your etiology, so cause and type of acute kidney injury. And that could be a very context-specific biomarker. So for example, in a patient with suspected sepsis, we may use a different profile to someone who's undergone trauma. And then the results of the context-specific biomarker may generate different treatment pathway depending on the cause, the anatomical site, and the supportive nature of treatment. So I hope that's given you an overview of, or my overview of biomarkers in clinical practice in the ITU. I'd like to thank you for your attention. I normally have a nice picture of Vicenza, but instead I've got a cartoon of the Worthing Pier where I live here on the South Coast. Many thanks for listening to me.
Thank you very much, Louis. And I think this is probably the very first public forum where the new definition classification based on ADKI resolution with the stage 1S has been presented. So this is very important because indeed, finally, biomarkers enter into the definition classification of AKI, which was in the past somehow subject and matter of discussion. It's now the turn of Dan Engelman to speak about post-cardiothoracic surgery, AKI. We had a couple of ADKI meetings dedicated to joined discussion with the surgeons about AKI, and I think Dan will refer to them and also will somehow include his view on the possible use of biomarkers. Dan, please.
Thank you, Claudio and Louis, for inviting me to speak today. And it's not nearly as exciting being in Vicenza as it is in my office in Massachusetts, I can assure you. But we have to do what we have to do, and hopefully next year. So I'm going to talk about the use of biomarkers in the management of cardiac surgical associated AKI. I am a cardiac surgeon. I'm that rare breed of cardiac surgeon that actually is interested in the mechanisms of AKI, and I actually believe that AKI is preventable following cardiac surgery, and that it should almost be a never event, that there are ways to ameliorate it and decrease it, and that biomarkers probably play a significant role in that process, and I'm going to be discussing that today. But as a little background, I'm also the president of an international society called ERAS Cardiac. I have no disclosures. I've declined any remuneration for this lecture, but I am the chair of the device safety monitoring boards for 3 Edwards life science valve trials that will not be discussed at all in this particular discussion. So fast track recovery of cardiac surgery. So I said I'm a surgeon, and I can't help but talk about some surgical things. I'm there on the left. That's my father, who's also a cardiac surgeon, on the right, and here we are operating together. And what happened was in 1994, he actually invented the term fast track recovery. And what he thought about was, why do we have to do everything so slowly? And maybe we could decrease a lot of the time spent in the hospital if we use certain interventions and move patients along in their recovery. And I sort of took that ball and turned it into something else, which was enhanced recovery, ERAS, and then published these guidelines for perioperative care in cardiac surgery in JAMA Surgery last year with these other international specialists. And then we formed this International Surgical Society. And why am I discussing that? Because one of the 23 guidelines with a class of recommendation of 2A was that biomarkers can be beneficial in identifying patients at risk for acute kidney injury. And then we discussed a lot of the studies which led us to that conclusion, including ones that were just discussed by Louis, including Pravaki and such, and also the general surgical study, which were randomized. So I'm going to talk about what every cardiac surgeon knows and does right now. So when I say our old standard, I'm talking about this is the present standard for the majority of cardiac surgeons in the world on post-op day 1 after cardiac surgery. Patients are maintained on vasopressors and inotropes as needed to keep their mean arterial pressure 65 and their cardiac index greater than 2. They give full dose, potentially nephrotoxic medications, such as some antibiotics, including Vanco and Gent, if they happen to be on them, ACE inhibitors, ARBs. They have a high threshold for blood transfusion, so we really try not to transfuse patients with a hematocrit that's over 21 or a hemoglobin over 7. We maintain this sort of random 30 cc's per hour of urine output based on prior studies. The problem is cardiac surgeons cheat. And what they do is they have their advanced practitioners or their physician extenders use a combination of diuretics and fluids, often at the same time, in order to maintain that 30 cc's per hour, that minimal 0.5 cc's per kilo. So it makes them feel good. Yes, my patient's still making urine. And then we use some type of monitoring, either a SWAN or a minimally invasive monitor, central line, arterial lines, and all that stuff comes out once the next morning they're off the pressors, they're making some urine, they look great, they're having breakfast, everything comes out, they go to the floor, and we move on. That's the standard of care. However, I don't have to tell this smart audience that serum creatinine is a lagging indicator of AKI development. I'm not even going to go over all the reasons why. This is for the surgeons when I give them this lecture about why it's not a particularly useful indicator of what's about to happen. And urine output is loosely monitored in most units. And why is that? One is we have nursing ratios that are rising. 2 is a lot of the urine gets either still in the bladder or it's in the tubing. It's not accurately measured hourly. And 3 is the ability of the urine output to predict subsequent AKI complications after cardiac surgery is practically nil. And that is because of our liberal use of diuretics. So it doesn't help if you just bolus the patient with 40 of IV Lasix, and you can say, well, they're not oliguric, so hence they're not meeting these standards of KDIGO AKI. It doesn't matter because we're giving them so much diuretic. And then I want to also talk about what's important to surgeons. So unfortunately, on the left here, we have the KDIGO staging, which everybody in this audience understands, stage 1, 2, 3. 3 being the tripling of your baseline, basically. But on the right is what the Society of Thoracic Surgeons, the North American surgeons that all report their outcomes, is only concerned with the old rifle criteria, which is stage 3 here, a tripling of your creatinine. So if you double your creatinine after cardiac surgery and the patient goes home, that's not reportable as AKI to our society, which is a problem. We need to include those. And why is that true? Because of the high incidence of mild, moderate, and also severe AKI, stage 1, 2, and 3, KDIGO. And you can look on the top line here for all types of cardiac surgery, as published by Hobson and Circulation. There's a 22% chance of stage 1, 13% of stage 2, 8% of stage 3, which all comers is a 57% have no AKI, so 43% have some AKI after cardiac surgery, which is crazy. Obviously, it's higher when you have the more complicated surgeries, but that is an enormous amount of AKI. And if we're just looking at the important stage 2 and 3 right here, it's over 20%, which I think is unacceptable and preventable. And the readmission rates after cardiac surgery, which we're very interested in because we pay for every readmission in 30 days after cardiac surgery, it does not get reimbursed. And you can see it directly goes up, almost linear, based on no AKI during the initial hospitalization, mild, moderate, and severe. So you really do not want to have AKI after cardiac surgery for this reason being 1. And 2, because of these articles which came out, which showed that even minimal changes in serum creatinine predict prognosis, poor prognosis after cardiac surgery. And when I tell this to the cardiac surgeons, they don't believe that a serum creatinine transient bump of 0.3, which is basically stage 1 KDIGO AKI after cardiac surgery, portends a 10% increase in mortality within 30 days. They don't believe it. They can't, they're just shocked. And short-term survival data continues when we look out to 90 days, as seen in 2013 data right here, where if you increase stage 1 to stage 2 to stage 3, we have linear decreases in survival over 90 days. So this is short-term mortality is absolutely increased with rising KDIGO stage AKI, and not just stage 3 AKI, within the first 90 days after cardiac surgery, even if that creatinine returns back to baseline. That's another thing that the surgeons can't understand. They think the creatinine bumped, it went back to normal, the patient went home, everything's great. And they always ask me the same question: why are these patients having worse short-term and long-term survival? And the answer, I think, my understanding is because of their increased risk of CKD, given that transient hit of a rising creatinine. And you can see right here, same story up to 10 years, rising stage KDIGO during that initial hospitalization is associated with decreased long-term survival. So clearly that's not good. And this just summarizes what I've just talked about: increased length of stay, increased hospital cost, increased readmissions, and increased mortality. So there's nothing good about the acute kidney injury effect after cardiac surgery. So what do we do and how do we do it? Well, in my hospital, we use the cell cycle arrest urinary biomarkers, IGF, BP7, and TIMP2, which provide the early detection of kidney stress and risk of AKI. And we developed a protocol to integrate the use of these urinary biomarkers into our multidisciplinary acute kidney response team, the AKRT. It's a stepped alarm system for everybody: the surgeons, the advanced practitioners, the nephrologists, the critical care physicians, and the nurses, that starts with the drawing of the urinary biomarker at 5:30 in the morning on every single post-operative cardiac surgical patient. It doesn't matter if they got out of the operating room at noon or they got out at midnight. At 5:30 in the morning, we batch it. Why do we batch them all together? For ease of testing, because it's too much of a burden to be sending them constantly throughout the day. And we picked what was easiest for my hospital. However, I got very lucky, as shown by Dr. Sean Cummings in this article in our surgical journal in 2019, because they took these batch 3,000 samples they had in the refrigerator and tested them for these two biomarkers, TIMP2 and IGF-7. And they showed a slight little increase when they came off cardiopulmonary bypass, almost no significant increase when they got to the intensive care unit. But this huge bump seen 6 hours after ICU admission, which continued through post-op day 1, which is exactly and coincidentally when I'm measuring my urinary biomarker. So if you have to measure this particular TIMP2 IGF-7, Shaw and Associates have shown do it on the morning after surgery. So that was lucky. And then I designed this test. This on the left just explains what AKI is and how you define stage 2 and 3 KDIGO, kidney failure. Not important for this group. What is important is on the right here. If it's negative, just as Louis pointed out, the negative predictive value is so important because these patients are fast-tracked, just like my father invented 25 years ago. We can take everything out and send them to the floor, assuming they're still making urine, which they all are, and have a negative less than 0.3 IGF-7, BP7. It allows for speeding up their recovery. You can use the ACEs, you can use the ARBs. We can give diuretics early and diurese them and get them out of the hospital. And we will not transfuse these patients unless their hemoglobin is absolutely below 7. Now, if we start getting into the higher range of greater than 0.3 is when we start putting on these interventions. What are the interventions? We keep the Foley catheter in place, especially if it's approaching over 2.0. We measure these urinary outputs. We avoid any nephrotoxin. There are no nonsteroidals. There are no ARBs. There are no ACEs. If they're an endocarditis patient or have allergies to penicillin and cephalosporins, we will stop their vanco and gentamicin. We may increase their transfusion threshold if they're still on some pressors. And if they become oliguric, they bump into this higher group where we use goal-directed hemodynamic therapy, which is we look for fluid responsiveness. We give a bolus of lactated ringers and we look to see whether or not we can increase either their stroke volume or increase their PAD, their pulmonary artery diastolic pressure, and increase their cardiac index as well as their blood pressure to improve O2 delivery to their stressed kidney. And we do this over and over again. And we do it with our nephrologist standing next to us every single morning on a lot of patients. So it's a multidisciplinary team that includes nephrologists, intensivists, surgeons, cardiologists, everybody's standing there. And we studied this and we compared the pre-biomarker group over a year to a post-biomarker group over the year when we started this in July of 2017. As I said, everyone gets it drawn in the morning on day 1, and then we put that protocol in place. It turns out what we looked at was 430 pre and 412 post biomarker patients and compared the two. And the demographics were absolutely the same between the pre and post groups. There's nothing different in demographics, patient status, or surgery type between the groups. Here are the comorbid conditions, essentially identical, pre and post. No difference between the groups. And we looked at all of their comorbidities, and they're all the same. And then we looked at their intraoperative variables. The only thing different was that in this period of time, our senior surgeons, 2 of them retired, and we took on 2 junior surgeons that had longer bypass times and longer cross-clamp times. So if you had to surmise, you would predict that the post-biomarker group would have a higher incidence of AKI because these patients had a significantly longer time in the operating room on pump. Here are our results. What's interesting is that 43% are negative. And as Louis pointed out, those 44% of patients can be fast-tracked. Very useful when you're trying to triage. I would say half the patients in the given morning, we say, perfect, pull everything upstairs. Now we have 55% of our patients where we have to worry and have to do a little bit more work, some of that goal-directed fluid therapy. And here's the actual histogram of the results. And you can see that 0.3, at this cutoff, there's still a sizable number that have them a little bit elevated, but not too many that are severely elevated right out here. That's the histogram. So what happened? This is where it all comes to fruition. This is the important part of this study. Before we started, we actually had a fairly low incidence of stage 2 and 3 AKI with a total of 2.3% of our patients, which is low compared to the national averages. But we took that down to next to 0. We had a single patient over the course of the year that had cardiac surgery out of 412 patients that had stage 3 AKI, one patient. We effectively have stopped dialyzing patients after cardiac surgery. It was one patient in that year. Seen right here in a different way. Here's the stage 1 with an 18% reduction, stage 2 with none, and stage 3 with only one case, which is a relative 85% reduction, which if you put together the 2s and 3s, they're really the most important. This is really the good summary slide. We went from 2.3% down to a 0.2%, which is a 85% reduction using this acute kidney response team guided by the stress biomarker as discussed earlier. Most common intervention. Most common, next most important thing to listen to if you're a surgeon is avoid over-diuresing patients on post-op day number 1. Now, you don't know which patients to give diuretics to. With a biomarker, you do know. You know which kidneys are stressed. The creatinine on post-op day 1 after cardiac surgery is worthless. It is always down. Why is the creatinine always down? Because these patients get huge amounts of crystalloid. They're put often on ultrafiltration while they're on pump, and it's too early to see a bump. So a creatinine, I tell my team, don't even tell me what it is on post-op day 1 because it's always normal. So do not over-diurese your patients, especially if they have very low filling pressures and some evidence of kidney stress. Stop the nephrotoxins if they have kidney stress. Raise your PAD because most commonly they're on the dry side. Now, not always. About 25% of our patients were fluid overloaded and their PADs were actually high, their CVPs were high, and they required diuretics. So while I say don't over-diurese, you need goal-directed hemodynamic therapy. Some patients are going to require aggressive diuresis because they've already gone over that curve and they're too full. And sometimes an echocardiogram helps you in assessing that. Give inotropes for depressed cardiac function to push up that index and the blood pressure if the patient has a positive urinary biomarker. Do a little bit more monitoring during that next post-op day number 1. Watch the urine output closely and get the nephrologist involved early. And in summary, all AKI rates dropped from 17 to 11%, stage 2 and 3 from 2.6% to 0.3%. The negative predictive value with a urinary biomarker of less than 0.3 was 100%. We never had a patient go into any stage AKI if their initial urinary biomarker was less than 0.3. So it was 100% sensitive, but only 46% specific because, as you know, a lot of them were positive and we acted on them, but it's probably a little bit too sensitive at that cutoff. We had no effect on length of stay, though you'd say, well, they stayed in the intensive care unit to have all these interventions. The other half fast-tracked out even quicker, which probably was the net reason. Plus, we had nobody require dialysis, which certainly increases your length of stay. And the readmission rates were unchanged for both groups. Now, further thoughts, finally, in my last few minutes, as the negative predictive value with this biomarker at a threshold of 0.3 was 100%, these patients may be candidates for liberal early use of potentially nephrotoxic agents. Hence, you might have thought, well, I don't really want to give a diuretic to a patient with a very, very low filling pressure, but we know they're fluid overloaded, maybe not intravascularly, but total fluid overloaded. So maybe giving early ACEs, ARBs, antibiotics, even some nonsteroidals is possible in these patients with negative biomarkers. And also a higher positive value, 0.7, may reduce the false positives without significantly compromising patient safety. What if we changed our negative biomarker level to 0.7 and went back and looked at the data? Then we would have 75% of our patients fast-tracked, and we'd only have to concentrate on 25% of our patients. That might be useful. Hence, that's why we've now changed our pocket cards. And our cutoff, you can see here, is this 0.3 to 0.7 are considered low positives. And the low positives get a small intervention. What they really get is 6 hours of close urine output monitoring. If they don't become oliguric, everything comes out, diurese them, send them upstairs and move on. They jump over to the negative group. If, however, in that first 6 hours, they start becoming oliguric without diuretics, then we put them into the high group, as we discussed more earlier, and we use some goal-directed hemodynamic therapy. So we're trying to kind of get more patients out quicker, and we're trying to really look closely at this 0.3 to 0.7 group. Now, IMPRESS, this has never been presented before. anywhere. It was only accepted for publication this week, is this title, which is Stress Biomarkers, in this case, IGF, BP7, and TIM2, do not correlate with risk factors for kidney injury following cardiac surgery. So the standard risk factors that everybody in this audience knows, traditional cardiac surgical associated AKI risk factors, do not differ between patients with normal or elevated urinary biomarker values. No difference in any of these risk factors. So a lot of people tell me it's an expensive test. I don't want to do it on everyone. I'm only going to do it on the high risk patients. So they go through this list and they pick patients that are at high risk and they measure the biomarker on them. It turns out there's no correlation. You cannot predict who's going to have a positive urinary biomarker. And that's because of something that Claudio taught me years ago, and that it's those patients actually have a normal creatinine, but have a no renal functional reserve. And unless you're going to do a test for renal functional reserve, which we're not going to do, we're cardiac surgeons, everybody just gets worked up and goes to the operating room, you can't figure it out. And every once in a while, we'll take a young person with a normal creatinine and operate on them, and their biomarker comes back through the ceiling, 99th percentile. And we pull apart the chart and go through it very closely. Basically, the nephrologist pulls apart the chart because the cardiac surgeons don't. And they'll say, you know what? 5 years ago, that guy came in for a colectomy. His creatinine bumped to 3. That's what happened. He had no renal functional reserve. Had we tested him, we would have known that preoperatively, even with a normal creatinine. So none of these covariates would have predicted that he would have kidney stress, which subsequently will develop into kidney injury after cardiac surgery. So in conclusion, the acute kidney response team triggered by IGF-7 and TIM2 and implementation of these stress modulators reduced the progression to AKI. The success is related to the successful formation and coordination of this multidisciplinary team, and future research is needed to determine the optimal level of these biomarker threshold to trigger the response team. I thank you all.
So thank you very much, Louis and Dan. We are actually running short of time, and we have no time for questions. I will just take advantage of my position of chairman to try to quickly summarize and give a few messages to the audience. First of all, we need biomarkers. First of all, biomarkers are what resolve situation of uncertainty that through the negative predictive value or the positive predictive value may actually help us to allocate better our resources. We have seen from Louis that now biomarkers are part of the definition classification of AKI as suggested by ADKI. And concerning the presentation of Dan, I must say that we had exactly the same experience, because in the past, we started measuring biomarkers in every cardiac surgery patient in our division. And what we found actually, and we published in NDT, we were able to reduce the number of cases of severe AKI and the number of patients requiring renal replacement therapy by approximately 20% just by implementing the typical KDIGO preventive protective measures. We all think we are good in doing this, but when you try to do a checklist and you try to apply the bundle, you discover that we're not so good. We may do better, and we are able to do better. In order to do that, we have invented and activated what we call the Nephrology Rapid Response Team, which involves from the beginning the nephrologist working together with the intensivist on the case. And I think that this addition is important. We have also used the so-called FAB4, the fabulous 4 parameters, which are basically history, physical examination, and risk evaluation, and finally the biochemical profile, including biomarkers. By doing this, and we have implemented this in a small application able to be used on the phone, we were able to achieve this result. The problem is that the administrators of the hospital sometimes are a little bit tight in money, And although you save money in treatments and cases, they are reluctant to spend a lot of money on this thing. The last thing I must say is there is no point to ask for a test, which is important to take a decision if you do not see immediately the response and you do not apply immediately your action. So please get in your hospital a system, whether you use point of care in different areas or so on, to be able to disseminate the information of the result of the test to all the people, which is basically what Dan has expressed as acute response team, and we call nephrology rapid response team, that are involved in the care of the patient. With this, I thank very much Daniel Engelman and Louis Forney, and also bioMérieux for supporting this fantastic symposium that is fully integrated in the program of our international Vicenza course on AKI and CRRT. I hope to see you next year in person, but for this year, certainly, at least we have the pleasure to interact virtually. With this, again, thank you very much, and hopefully see you soon.